Okay, good afternoon, everybody. Thank you so much for joining us for today's webinar on stroke recovery and support. May is National Stroke Month, and so we have quite a few webinars for you. Today is the first in a series of stroke webinars that cover an array of topics about stroke that'll last throughout the month of May. Today, we're going to learn about what to expect after a stroke, what recovery looks like, and how that it's different for different people. We will also discuss the supports that are available to stroke survivors and their families. We have some wonderful expert speakers for you today, but as always, we have a couple of housekeeping items just before we get started. First, the Q&A and chat box will both be open throughout this presentation, so please feel comfortable in using those to ask questions. If you aren't able to use that Q&A and chat box for some reason, you can email me at dharman@arh.org, and I have my phone here beside me, so I'll answer those as we get them. If you have asked questions via email beforehand, I do have those in front of me. If they're not answered within the presentation, then I'll ask those questions for you at the end in our Q&A section. Our doctors and expert speakers, of course, cannot answer specific medical advice or make referrals to you. So if you should need specific medical advice about your own health, or if you need your own referrals, please contact your healthcare provider. If you do not have a primary healthcare provider, please visit arh.org, where we have a listing of our own providers that would be happy to help you. Now, our first speaker is Dr. James Hammock. Dr. Hammock is the Medical Director of Rehabilitation Services, and he works out of Hazard, Appalachian Regional Healthcare. He attended and graduated from the University of Louisville School of Medicine in 2008 and has over 13 years of diverse experience, especially in physical medicine and rehabilitation. Dr. Hammock is also affiliated with and works often with the University of Kentucky Hospital. So Dr. Hammock, I am going to kind of hand you the reins over and let you do your presentation. I'll pop back in at the end of your presentation and introduce Ms. Keisha, so please take it away.
All right. Well, Danielle, thank you. Like she said, my name is James Hammock. I go by Jay Hammock, but I'm a physical medicine rehabilitation physician with a focus, clinical focus in neurorehabilitation, both stroke, brain injury, and spinal cord injury. But a love of mine is stroke recovery. So we're going to be talking about stroke recovery today and the way that patients can optimize their functional recovery after a stroke. So the quote of the day that's very specific to this lecture is a quote by Aristotle, that we are what we repeatedly do. Excellence then is not an act, but a habit. And you'll see how that comes into play as we go along. So we have some basic objectives, and to understand the basics of stroke recovery, to explore kind of the most common stroke recovery patterns, what issues that we commonly run into in stroke recovery, ways that a multidisciplinary team can optimize stroke recovery, and then newer approaches to improving stroke recovery. Okay, so the basics of motor recovery, or if I've left any motor recoveries in here, when I say motor recovery, that is stroke recovery, but specific to strength recovery. So the medical literature dictates 3 determinants of stroke recovery. And number 1, it's the timing, intensity, and training approach. Number 2 is the neuroplastic milieu, or the conditions in the brain right after a stroke that will determine whether an outcome is good or bad. And then the third is the extent to which the brain is able to reorganize certain nerve pathways. So neuroplasticity is the key issue when you're talking about stroke recovery, and it's only, our knowledge of neuroplasticity has only really been around since the early 1950s, when we defined it as the ability of the brain to form and reorganize connections between the nerves, especially in response to learning or experience or injury. And it's evolved more rapidly over the last 20 years. So this is neuroplasticity. Neuroplasticity is really the engine that drives stroke recovery. So these are just, the actual terms you really don't need to understand. You don't need to memorize. But this timeline is key to stroke. And 20 years ago, we still thought, and it was just starting to change, we still thought that once you had a stroke, whatever functional deficits you had at that point, that's kind of what you were stuck with the rest of your life. And we've come to find out over time that that's not necessarily the case. So as you'll see in this timeline, so the insult is the time of stroke, that there was actually tissue damage to the brain. Your brain will attempt plasticity or reorganizing parts of the brain or reestablishing the same connections or secondary pathways. And it'll do this within the first primarily 180 days to about 12 months. It will devote a higher cerebral metabolism to recovery. After that time, the likelihood of significant recovery drops significantly. So the first phase of neuroplasticity is the hyperacute. So this is the first 6 to 8 hours after a stroke. When you start to get resolution of swelling and the brain starts to kind of acknowledge what parts were damaged and what parts were damaged beyond repair. And then it starts to reperfuse, or it starts to bring blood into parts of the brain that were damaged, but it's able to recover. So the acute phase is when we get past that first couple of hours to a couple of days, when your brain actually starts to reorganize its connections. And it'll do this by either repairing the pathways that are that exist, or developing new pathways, or recruiting neurons close by to create new pathways. And it does this readily, but you have to put the brain in a position where it can perform these tasks appropriately. And if you don't do that, that's when you get into significant functional loss without recovery. So the subacute to chronic phase is well past the point of acute rehabilitation, and you're getting into abnormal pathways that the brain starts to utilize. So motor learning has been around for decades, but we've only really started to understand it the last 20 to 30 years. But it's affecting neuroplasticity by learning new motor plans and refining behaviors that we knew previously, like brushing your hair or brushing your teeth. And it's how this repetition is how we can facilitate, amplify neuroplasticity. And this is just with practice comes recovery. And this is kind of how my team or an acute rehabilitation team like the one here at Hazard ARH or any other acute inpatient rehabilitation unit, this is how we start the recovery process, is by identifying our functional goals early on, and trying to line that up with the patient's goals for themselves. And that's very difficult to do, but that's one of the important parts of getting into rehabilitation early, so that you can start this process early. So the way that I do this is positive thinking and imagery, and it may sound hokey to most people to think, oh, I can think that I'm going to get better and I can imagine it, and that's actually going to do anything, and it does a lot. And your brain can start to recover just by you recurrently picturing and targeting normal behavior, normal tasks. And then after that, we start to devise creative activities that are progressively difficult, but are also goal-directed for both the rehabilitation team as well as the patient, and utilizing positive feedback. And we also integrate training objectives with meaningful functional activities. We're not just trying to strengthen your hand. We're actually applying that to a task that is going to be specific for a patient. And every patient's a little different as to what tasks they find salient. And we also avoid training activities which reinforce abnormal movements. And a lot of times, if your hand isn't working appropriately, what a lot of people will do is just use their opposite hand, or they'll use this hand in a way that does not stimulate the brain into recovering that normal pattern. So we avoid training activities that reinforce those. Maintaining self-esteem, and again, some of these things, kind of sound hokey to somebody who hasn't been through this, but it's very important. And your motivation, your sense of self in this process is very important, and can set you on a trajectory, for some that is very positive, and for some not so positive. But we also try to cultivate an enriching environment where the patient, their brain are progressively and consistently challenged, but we also want to maintain an environment of discovery and possibility and fun. And I very rarely, in a patient's first week with me, I very rarely talk about what 6 months, 8 months is going to look like, because the reality is I can give them what the literature says, but everybody's a little different, and there's so many factors involved with their recovery process. It is not helpful or healthy for me to talk about the worst possible scenario, which is a lot of what the literature talks about. So again, kind of reinforcing the positive neuroplasticity, what positively influences your brain to recover. So mental stimulation, specific intellectual pursuits of an individual patient, social interaction, which has been a really tough issue during this COVID pandemic, good emotional health, exercise is part of what we do, proper nutrition, proper sleep. All of these things are important in promoting neuroplasticity. And so the things that negatively impact neuroplasticity are the opposite. So social isolation, not paying enough attention to your emotional health, sedentary lifestyle. Always about 1 in 20 patients will say, well, I just want to go home and I want to do this on my time, which I understand that, but there is no replacement for active rehabilitation. You just can't do it. We may have the best thoughts and everything, but typically it does not end well for someone who tries to set their own pace at home. So again, incorporating all those will lead to expansion of healthy nerve cell populations and nerve connections. You get increased volume of brain centers and delayed atrophy of the areas of the brain that are affected. You get faster and more reliable nerve interconnections, leading to improved sharpness and attention, and improved ability to recognize and maintain trunk and joint position, gait stability. And this again is motor learning, driving neuroplasticity. So I'm sure, like this says, based on all the head tilts that I can't see, but I can feel, maybe I better explain this again. But what we're moving into now is describing common stroke recovery patterns. And these were described by a doctor named Brunstrom, but he described stages of recovery from someone who was completely flaccid, meaning they had no movement capability at all on their affected side, to someone who had complete return of function. And there is no standard time interval between these stages. But in general, the faster you achieve the next stage, the more likely you are to progress further down this line. So again, the stroke onset, and you have a loss of functional ability. And as we go along, someone who gets acute rehabilitation will progress to a point where typically they'll flatline. You have about 10 to 15% who can make some mild to moderate functional gains after that 12 months. And you have those who discontinue their home exercise program or something like that, and you'll get a decline over time. And that's again about 5 to 10%. Another doctor named Twitchell described typical anatomy patterns of recovery. So your upper extremity is more commonly affected than your lower extremity, but the lower extremity recovers more rapidly, and that's because the brain devotes more metabolism to recovery of that part of the brain, because you need those neurons to be able to walk. And patients are more likely to have long-term functional sequelae due to residual arm weakness. So complications that impact neuroplasticity, and again, the reason why inpatient rehabilitation is necessary is infection. Pneumonia, urinary tract infections are very common, and they're much easier to diagnose in an inpatient setting than outpatient. Medications, so first generation antipsychotics like Haldol should never be used. Newer antipsychotics have some of the same issues, so we try to disengage with those types of medications. Benzodiazepines like Xanax, And then anticholinergics like Benadryl are to be avoided at all costs. And then depression, the literature still says that roughly about 50% of patients, whether they had mood disorder before the stroke, will have some sort of mood disorder, whether it be depression or anxiety, after the stroke. And in my practice, I would say that's probably more like about 75%. So another thing that is not common, but it can be a huge problem, is a recurrent stroke or hemorrhagic conversion. So your risk of stroke over 5 years is about 13% at the first year, 30% over 5 years, and the incidence of hemorrhagic conversion, or a stroke turning into a bleeding stroke, is around 7 to 9%. And again, these are things that need to be diagnosed in the inpatient setting, but they typically delay rehabilitation and expand the neurological impairments. Another complication is a fall with injury. So stroke patients are almost 2 times more likely to have a fall with injury, and it's due to the fact that strokes affect balance and balance confidence, and they commonly lead to fractures with activity restriction, fear of falling, and depression, which further limits neurological recovery. So how do we optimize recovery? So number one is you initiate acute level inpatient rehabilitation in a timely manner. And this is usually 48 to 72 hours is the preferred time range. There's still some question whether you can bring a patient earlier than 24 hours, but in most settings, unless it's a huge trauma center, typically you can't move them within 24 hours anyway. The second is exercise, so aerobic, strength training, flexibility, neuromuscular re-education. It should happen at least 3 days per week. And in an acute inpatient rehab setting, you will typically get 3 hours per day, 5 days per week, which I'll always tell my patients in a 5-day course, you're going to get about a month and a half worth of outpatient clinic therapy. So there's no replacement for acute level rehab. So strength training, again, this is part of what we incorporate is 2 to 3 days a week. Flexibility training is important, primarily because muscle tone issues are very common after a stroke, and maintaining your flexibility is key. So neuromuscular re-education, balance and coordination exercises. And again, this is much easier to do in a controlled environment in an acute inpatient setting. So the goals of exercise after stroke are to increase your activities of daily living independence. So brushing your hair, combing your teeth, dressing, all those kind of things. You're increasing walking speed, efficiency, and balance. You're bolstering your tolerance for physical activity, and you're improving joint extensibility and proprioception, or knowing where your limbs are at in space, which is something you have to retrain your brain. The secondary goals are to reduce the risk of further cardiovascular or cerebrovascular disease and reduce the risk of stroke-related complications. We've already talked about task-specific training. So some of the specialized treatments that we can get into is mirror therapy. And I think I have, so here's an example of mirror therapy. So this is kind of tricking your brain into thinking. So this is her good limb here, and it is tricking your brain into thinking that you have two good limbs. And like I was telling you before, it may sound kind of hokey, but imagery is very important in neurological recovery. So this is actually tricking your brain into thinking that this limb is not as affected as it really is. So constrain induced movement therapy is where we will constrain the non-affected limb and require the patient utilize their affected limb primarily. And this works quite well for patients who are a little further advanced in the recovery process. But again, these are very task-specific exercises. So another thing that we'll do is either on the floor gait training or body weight supported treadmill training, which is more for patients who have a higher degree of weakness and stability issues, and we will support their body weight but allow their feet to touch and go through gait patterns. Musical or music supported therapy or musical intonation therapy are newer protocols that sync functional tasks with music. And those are becoming more commonly integrated with an acute rehab stay. But these protocols utilize musical instruments, music directly to train fine and gross motor tasks. Some of the newer ways we improve function is something called transcutaneous neuromuscular electrical stimulation, which is very similar to a TENS unit that patients will use for muscle spasms and the like. But this is actually stimulating the muscle to reestablish a connection between the brain and the extremity. So the functional electrical stimulation can be applied to home-based programs, and frequently are, especially for someone who has significant residual deficits. And what we're getting into at this point is a lot of robotics training. So this is incorporating functional tasks with a robotic mechanism. And these are some higher end machines, but the first one was a pretty common device. And this is something called a Locomat, but it's a combination of a robotic and body weight assisted device. So the advantages of that is precise, intensive, specific, and again, these technologies are becoming much more common. And then these are getting to be, they were experimental 5 to 10 years ago, but we're getting into non-invasive brain stimulation, where we actually stimulate part of the brain electrically and coordinate that with a task-specific exercise. And again, that's to retrain and reconnect the neurons that have been affected. So this will be common practice in the next 5 to 10 years. Brain-computer interface, again, you see videos of this quite commonly now, where they're placing superficial electrodes and teaching a patient to do a task-specific activity despite not having recovery of this limb. So again, these are a little further out, but they will be commonplace in the next 5 to 10 years. And then virtual reality is something that we do have access to now, but it is providing an avenue for multisensory immersion and providing a safe way to do upper extremity tasks, improving ADL outcomes. It's a more technologically advanced type of mirror therapy. And that's just the kind of the basics of stroke recovery and the importance of getting into acute level rehabilitation after a stroke. But if you have any questions, please let me know.
Thank you, Dr. Hammock. So we're going to let Keisha do her presentation or talk to us really quickly, and then we will come back to you at the end and ask you just a couple questions. So Keisha, if you don't mind to step over as you can. Keisha Hudson is our next speaker, and Keisha is the Administrative Research Assistant Senior at the UK Centre for Excellence in Rural Health. Keisha organizes a stroke support group as well and a camp for stroke survivors. And she's going to tell us about both of those. Keisha, thank you so much for being here today and on short notice. So I really appreciate you being here with us.
Thank you for having me, Danielle. And
No
as
problem.
she said, I'm Keisha Hudson, and I work at the University of Kentucky Center of Excellence in Rural Health, which is located literally in the parking lot of the Hazard ARH hospital. And I just want to take a quick second to thank Dr. Hammock for all he does for our stroke survivors and our community. He's been a vital role in our support group and helping us create it. We worked with Dr. Hammock and his team up on the acute rehab unit at Hazard ARH. Back in 2014, we had a pilot grant to pilot a stroke navigator on the unit. So we partnered with them to do that. And out of that became our stroke support group. I founded that in 2015. And our group it's more than just a support group. We're very active in the community as far as stroke screenings and stroke education. And we have members that are in our group from Perry and the surrounding counties. We meet once a month at our UK center here in Hazard. But due to COVID, we have been meeting virtually for the past year, almost year and a half now. And so we have increased some members through Zoom, more out in the Eastern Kentucky region. So we would like to keep them involved. And just working over the years, it's been a passion of mine to have a stroke camp. I've talked to our director, Dr. Feltner, one of our PT faculty who piloted the Stroke Navigator project, Dr. Pat Kitzman, and Danielle got to meet him last week. So I've been hounding everybody about a stroke camp. So if the pandemic did one thing, it slowed us down, and we were able to find the perfect grant, write the grant, and get funded for a stroke camp here in Eastern Kentucky. This will be one of the first stroke camps that we're aware of in Kentucky. We have them in surrounding states, but that will be coming up in September. September the 25th. I can get the save the date out to Danielle and she can distribute that. We're going to have it at the Buckhorn State Resort Park, and we will have adaptive fishing. We'll have adaptive games. Dr. Hammock has graciously accepted an invitation to be our keynote speaker. We will actually have music therapists on site as Dr. Hammock was alluding to, the fact that a lot of the research shows that music therapy works. We've had a couple of our stroke support group members that have been fortunate enough to get music therapy. And we've had a music therapist join our support group, and we were able to all sing a song together. So that was fun. Didn't release that to the public because nobody wants to hear me sing. But it really helps a lot of our stroke survivors. One thing that our group also does is we include the caregivers as well. So stroke survivors and their caregivers can join our group. We do have some families that just the caregiver comes. So if you know anybody that has had a stroke in your area, we do have a referral form. We have a flyer that we could get out to everyone. We're just really excited about this camp. It will become an annual camp. We're going to make sure of that. So once we work out all the kinks, I'm really excited about it. So anybody from Kentucky, specifically for this Eastern Kentucky region, is more than welcome to come to our camp. We will be releasing our registration probably in July, but we do have to say the date that I can get out. And we are doing a virtual webinar June the 15th just to promote for our camp. So I can get all the information out to Danielle, Dr. Hammock, and they can share that with anyone else that's interested.
Thank you, Keisha.
Thank
I
you.
will certainly share that. We have the email addresses for everyone that is a registrant and a participant today. And so we can send those out to everything that you have from your support groups. And before you put your mask back on, I have another question. Maybe you take your mask off. Apologize. So
Okay.
you mentioned your support group, and I know a lot of people are trepidatious about coming out because they think they have to speak in front of people. So can you just kind of tell us what one support group would look like? So if someone were to come either in person or via Zoom, what do you guys talk about? And are people required to speak and kind of tell their stories, or just kind of ease some fears about those support groups?
Sure. No, our support group's very inviting. Actually, we joke around all the time that we have become a family. It's just become its own entity, actually. I've had people come for the first time. I've had caregivers come up to me and say, so-and-so will not speak. Please don't ask them to share their story. So that happened with one of our members who was also a veteran. And so I didn't call on him to speak or say anything. And he actually was offended. He's like, hey, what about me? I want to speak. So he spoke, and he really hasn't shut up since. So it's just, I feel like our group's very inviting. We also, I let the group members, whether it be the stroke survivors or the caregivers, tell me what topics they want to learn more about, or maybe something they're unclear of, or something that they want to try out. And, you know, Dr. Hammock talked about how if we think positive, then we can do something. There's such a great support for each other. Just an example, one of our stroke survivors came to the meeting one month, and he's like, hallelujah, I was able to cut my own toenails. Well, someone else in the group had been really struggling with that and didn't think they could do it. So they get home, tell their wife, well, if he can do it, I can do it. So I got a call not too long ago after that, and they were able to do that too. So it's just very inviting to, I feel like, to the survivors, especially, to meet people that's going through the same thing that they are. It's just, it's not a group where we just stand up and lecture at you. It's a sense of support, a sense of family, and no judgment. You can speak as little as you want, or you can speak, well, I won't say as much as you want, because sometimes I have to cut some people off just so others can share in speaking. But it's Dr. Hammock will come to the meetings, and he will offer support to anybody. He's graciously answers questions for our members in a way that they understand. So really all I can say in a nutshell is that it's very inviting. Anybody that's scared, I would say come try it one time, and if you don't like it, then fine, never come again. But we haven't had anybody join our group that has just completely quit coming to the meetings.
That is wonderful. So what kind of topics? Do you cover a different topic every support group as far as nutrition or, you know, therapy topics or anything like that? Or do you just open it up?
We do. Again, I let the stroke survivors and the caregivers actually too tell me what they want to learn more about. So if it is nutrition, then we will have a dietitian come in and speak. If it is stroke recovery, Dr. Hammock's always my go-to person, but we also have physical therapists. We have occupational therapists that come in and speak. You know, we have our physical therapy students right in the building where I'm at UK. So we call upon them a lot to come and do demonstrations for our survivors and our caregivers. We try to have a guest speaker at every single meeting to cover different topics, but every now and then we'll just have a meeting just to check up on each other, just to come together and talk about feelings and things going on with each other and share stories.
Fantastic. Can you tell us again, if someone wanted to join your group, how would they go about doing that?
Absolutely. I do have a flyer that I can share with you. We've just recently had a graphic design created for our support group. If you've seen anything about the Hazard and surrounding area stroke survivor and caregiver support group, that is our group, but we are officially called the Eastern Kentucky Stroke Warriors now. We do have a Facebook page, so you can just look up Eastern Kentucky Stroke Warriors, or I will share the flyer with you. Or you can also contact me, and my email is Keisha, keisha.hudson@uky.edu, or just call me at the Center of Excellence and we can get you involved.
Thank you so much, Keisha. And that is a free service, correct? Your support group and the camp will be free as well.
Absolutely.
Okay, perfect. Thank you so much. And with that, I think you can put your mask back on. We don't have any more questions at the moment. And if you don't care to switch places again with Dr. Hammock.
If I can mention, Danielle, our stroke camp, we are partnering with LKLP to do some transportation. So if someone wants to come to our camp and can't get there, they can contact me and we can work out transportation issues.
Perfect. Are there any other supports before you put your mask on? I know this is the second time I've told you to put it on and take it off. So are there any other supports for just general getting to your support groups or getting to therapy or getting to their doctor's appointments for stroke survivors? Gas cards, anything of that nature that you know of?
We do have some resources, some people that we work with. As far as any supports to getting to and from the meetings, no, that is something that I have been wanting to work on, and hopefully transportation's horrible in this area, especially in a rural area. So that's something that we offer Zoom. Even when we meet in person, we still offer a Zoom connection just because we have a lot of our speakers that will Zoom in, and anybody that's not in the area that can. We do have a mini grant that we are the holders of for stroke survivors that we do a funding cycle every year that does help with transportation issues, extra respite care, therapy. That window actually just closed and we're reviewing those applications now. So we can do funding through that way, or there's all kinds of resources out there that if someone needs that I could connect them to.
Thank you so much.
Thank you. Am I good?
Yep, I think you're good. Back again, Dr. Hammock. Thank you so much. So I know that one of your slides and what I hear a lot is about the importance of relationships and maintaining relationships and maintaining your lifestyle and active lifestyle. So can you talk a little bit about that? And since Rachel just talked about the support groups especially, but kind of maintaining your physical activity, but also your intellectual stimulation and how important that is for stroke survivors.
So it is very important, and we try to, and I always take this back to acute rehab, but we always try to incorporate some of those factors early on and engage anyone who's going to be close to the patient, who's wanting to help in some way. But it is very important to maintain your self-esteem, your sense of self, because that takes a significant impact in a stroke. I mean, you come the day before, you feel like you're one person, and then the day of, you're this completely different person. And it really takes a village to help someone through that period of time, because it is hard for most people to come to terms with the functional deficits that have arisen. So we try to engage everyone involved to help with that. But in terms of intellectual stimulation, like I said in the lecture, the important thing is not only repetition of a task, it is also giving your brain a novel task to not only repair nerve pathways, but also engage different parts of the brain to function as that primary pathway, even though it's a secondary pathway, to function as that primary while the primary is being repaired. And that's important not only in the acute period, but also in minimizing any cognitive deficits past that 1 year.
Thank you. So with that, you mentioned home-based programming, and there are lots of things that we can do, of course, within rehabilitation. I think you mentioned like 3 hours a day and 5 days a week. So a big time commitment for you and for when they come into rehabilitation services, but even more so at home. Can you talk about the importance of continuing that therapy at home and continuing, everything that they're learning from you and from your therapists on their own time?
So typically, the acute inpatient stay can last anywhere from as short as 7 to 10 days to as much as 28 to 40 days. And after that, there are several levels of rehabilitation that you can transition to from that. For the least functionally impaired, it would be home health, physical therapy, and occupational therapy. For the more functionally dependent, it could be a swing bed facility, which is a transitional unit back to home. For those that have severe functional deficits, but also severe medical issues, sometimes they will require more intensive rehabilitation for a longer period of time. So it vacillates back and forth between about 5 to 8% of patients will go to a skilled nursing facility for a certain period of time and then return home. Upon completion of all those, and again, during that first year, we're going to exhaust every avenue of rehab, whether it's acute, subacute, home health, outpatient. But it's imperative that the patients learn a home exercise program and maintain that home exercise program for the rest of their lives. So it's not just a 1 year and then I can stop doing everything. It's a commitment to maintaining your home exercise program for the rest of your life.
Certainly a lifestyle change.
Yes, definitely.
Well, thank you very much. I don't see any other questions. We haven't had any more come through on email, and the one that was on our Q&A has been answered. So I really appreciate you, Dr. Hammock, and Keisha, who's still in the room there, I think, with you. So thank you guys so much for being here on our webinar series today. As great information, I think that is very, very, very important for everyone to understand. So lastly, before we leave, I want to remind everyone that this is an incentivized series of webinars, as I mentioned before. So those of you that attend 3 out of 4 of our webinars are going to be entered to win a Feed Your Brain kitchen appliance makeover. So you're going to receive an air fryer, an Instant Pot, a NutriBullet, and a bunch of other cool stuff. The one grand prize winner will receive all of that, and that's going to be drawn from the people that attend 3 out of 4 of these webinars. So our next webinar is scheduled for May 10th, and it's going to cover the topic of stroke in women with Dr. Kara Swafford from UK. So Please find our registration if you haven't already registered for that. You can find the registration forms on our ARH Facebook pages. So with that, we end our webinar, and I thank you guys so much for being here again today. Thank you for our participants, and thank you, Dr. Hammock and Keisha Hudson. I really appreciate you guys, and we hope to see you again on the 10th. Thank you, and stay safe out there.